Hello everyone. Today we are going to see some lower limb conditions. So first one is the prepatellar bursitis. As the name says, there is a bursa which is in front of the patella. So that is prepatellar bursa. When that bursa is inflamed, it results in this condition, that is prepatellar bursitis. Here the patient will be presenting with an anterior knee pain, when especially this happens with those who are frequently on the knee. So it is also known as housemaid's knee, but it is common in painters, plumbers, or those which occupation requires kneeling. So since it is bursa is inflamed, that is there is an inflammation, non-steroidal anti-inflammatory drugs are the first therapy. If the bursitis is very severe, then aspiration may be required. What happens in patellar tendonitis? Patellar tendonitis is also known as jumper's knee. Here, the patellar tendon is the tendon which attaches the patella to the tibia, isn't it? So, when that tendon is inflamed, it will result in patellar tendonitis. The initial presentation will be anterior knee pain that initially occurs only after finishing the sports activities. Why? Why should it occur only after the sports activities and not during the sports activity? This is because of the way tendons adapt to and recover from activity. The tissue damage that builds up over time may not show immediate symptoms during the activity itself, but inflammation and pain often become apparent after the body has had time to cool down and the stress on the tendon accumulates. With the time, it will gradually progress to become more chronic and persistent. So now the treatment is aimed at strengthening the tendon as well as the muscle. So therefore, quadricep strengthening exercises is the treatment. What is patellofemoral instability? Patellofemoral instability is that where there is misalignment of the patella at the trochlear groove of the femur. Since there is misalignment, there is knee pain which is worsens after jumping or running, and since there is misalignment, it also presents with crepitus. So they will present with a high yield is teenage girl with knee pain after activity plus crepitus. So when there is crepitus, then it directly points towards patellofemoral instability. What about patellofemoral pain syndrome? Here, what happens is that it results from a combination of factors that cause abnormal stress on the patellofemoral joint, where the patella glides over the femur. Fine. So the exact cause for this patellofemoral pain syndrome will vary, but it can be because of abnormal patellar tracking, where the patella normally moves smoothly in the groove at the end of the femur. When there is misalignment or abnormal tracking of the patella, such as it moving out of the groove, it can rub against the femur, cause irritation, and it can cause pain. So this is the main reason for patellofemoral pain syndrome. But why does that happen? This can happen due to various issues like muscle imbalances, tight ligaments, or structural abnormalities in the knee. Fine. So how will the patient present with pain worsens when sitting for long periods or climbing stairs? And it is classic in obesity or those who do heavy squat weights. Quadriceps strengthening exercises are again the first line therapy. What about the cruciate ligament anatomy? There is anterior cruciate ligament and there is a posterior cruciate ligament. Anterior cruciate ligament is nothing but it will originate from the medial aspect of the lateral femoral condyle and it will get inserted in the anterior aspect of the tibia. So this is the lateral femoral condyle, medial aspect of the lateral femoral condyle and in the anterior aspect of the tibia. But whereas posterior cruciate ligament will originate from the lateral aspect of the medial femoral condyle and it will get inserted in the posterior aspect of the tibia. So this is the cruciate ligament anatomy. When does anterior cruciate ligament injuries happen? The injury will happen when there is excessive anterior tibial displacement. Why? Anterior cruciate ligament is the ligament which will attach itself to the anterior tibia, isn't it? So when there is an excessive anterior tibial displacement, then the anterior cruciate ligament has to give way. So, and it has to get injured such that anterior tibial displacement will result in anterior cruciate ligament injury. So how will one test this? that is known as positive anterior drawer or Latchman test, where one can find that the anterior cruciate ligament is injured. What about the posterior cruciate ligament? Here, the posterior cruciate ligament will attach itself with the posterior aspect of the tibia. So, any excessive posterior tibial displacement will result in posterior cruciate ligament injury, which is tested by positive posterior drawer test. Fine. So, the classic mechanism for posterior cruciate ligament injury is knee hits the dashboard in a car accident, resulting in excessive posterior displacement, resulting in posterior cruciate ligament injury. What about the lateral collateral ligament injury? The lateral collateral ligament is the ligament which is present in the lateral aspect of the knee joint. So, the mechanism of injury is that often from a lateral impact. When there is a lateral impact, it will result in a lateral collateral ligament injury. Varus stress test will reveal excessive lateral knee motion. What is varus stress? Varus stress is pushing the knee joint medially. Since the lateral collateral ligament is injured, there is nothing to hold it laterally. Therefore, there is excessive lateral knee motion. How does this test done? In this test, one hand pushes the medial knee outward and the other hand pushes the lateral ankle inward. So, in this way, when the lateral collateral ligament is injured, there is excess of the lateral knee motion because there is nothing to hold the lateral knee at that point. What about the medial collateral ligament? Here, valgus force is applied to the knee joint. How is this test done? Where a hand is placed on the lateral knee, pushing it inward, while the other hand pulls the medial ankle outward. This is how the valgus test is performed. So, since the medial collateral ligament is injured, there is nothing to hold the knee joint in the medially. So, therefore, valgus stress test reveals excessive medial knee motion, indicating that the medial collateral ligament is injured. So, we should know which test is applied for which ligament injury. So, here in the lateral meniscal tear, there will be lateral knee pain with locking or catching during partial flexion. So, to diagnose a lateral meniscal tear, we will have to do the McMurray test. What is McMurray test? In McMurray test, the patient lies on their back supine with the knee in a relaxed position. The examiner stands beside the knee, besides the patient, facing the knee that is to be examined. So, initially there will be a knee flexion, like the examiner holds the patient's leg with one hand around the foot and the other around the knee joint. The examiner fully flexes the knee to about 90 degrees to ensure the joint is in a flexed position. Now, this puts the meniscus in a more vulnerable state where tears are more likely to be detected in this 90-degree position. Now, rotating the knee, external rotation for lateral meniscus is done. So, to test for the lateral meniscal tear, the examiner will externally rotate the tibia while applying a valgus stress to the knee, that is pushing outward on the knee joint from inside. The tibia is then slowly extended from a flexed position while maintaining the external rotation. As the examiner extends the knee, they are feeling for a click or a pop or a catching sensation that may occur in the lateral joint line. These are signs of torn lateral meniscus. The examiner may also note any pain that the patient report along the lateral aspect of the knee. In this way, the lateral meniscus tear is diagnosed. So, how do you diagnose a medial meniscal tear? So, here the McMurray test is done, but there are few changes in it. The patient is made to lie on their back in a supine with the knees relaxed and bent slightly. The examiner flexes the knee to about 90 degrees to put the meniscus in a position where it is more likely to be stressed during the test. To test for a medial meniscal tear, the examiner internally rotates the tibia while applying a varus test, that is pushing inward on the knee joint from the outside. This is because the medial meniscus is put into stress only at that only with that force. The tibia is then slowly extended from a flexed position while maintaining internal palpation rotation. As the knee is extended, the examiner feels for a click or a pop or a catching sensation along the medial joint line. These signs suggest a medial meniscal tear. The examiner can also note for any pain that the patient reports along the medial aspect of the knee. So, the main difference is that for a lateral meniscus tear, the tibia is externally rotated and the knee is pushed outward so as to stress the lateral meniscus. Outward is valgus. But whereas in a medial meniscus tear, the tibia is internally rotated and the varus pushing inward on the knee so that the medial meniscus is stressed. So this is the difference in the McMurray test for medial and the lateral meniscus tear. What is an unhappy triad? Unhappy triad is nothing but there are three combined injuries. A common pattern of three simultaneous knee injuries. One is the anterior cruciate ligament, the other one is the medial collateral ligament, plus either the medial or the lateral meniscus tear. So when these three are combined, it will result in an unhappy triad. What about a pes and serine bursitis? There is a bursa which is present on the infero-medial aspect of the knee. So this is seen in runners, swimmers, or also in obese patients. The diagnosis is when there is an infero-medial knee pain. Mostly since it is inflammation, bursitis, NSH, rest and physical therapy are the treatment. What about neurogenic joint or a Charcot joint? In neurogenic joint, there is a lack of sensation because of the peripheral neuropathy. So it can be seen in advanced diabetes or in neurosyphilis also. So what happens is that because they are not able to feel the pain, it results in repetitive microtrauma to the joints as well as to the tissues without the body's natural protective mechanism. So since there is no pain, that is resulting in a disorganization of the joints. So in a patient with a neurogenic or a Charcot joint, they will be having disorganization of the tarso-metatarsal joints on the foot X-ray. This is a high-yield diagnosis in diabetic patients with foot abnormality. What is a growing pain? A growing pain is a condition which will affect the growing bones, mostly in healthy children between the age 3 to 12. The patient will wake up in the night and they will have severe leg pain, throbbing leg pain, such as we might be even suspecting some other serious conditions. But it is nothing but it is growing pains. There is no treatment necessary beyond reassurance. So before we go into Osgood-Schlatter disease, we should know what is apophysis. Apophysis is a bony prominence of a bone or the growth plate. So here, where in that bony prominence or in that growth plate, the tendon of the muscles will attach. This is one thing. Second one is that apophysis is a secondary ossification center where it is still developing and it is not yet fused with the bone. And it is present in the children and adolescents. So what is traction apophysitis? There is inflammation of this apophysis bone because of traction from the muscles. Why should the muscles cause traction and inflammation? That is because of overuse or repetitive stress. So because of overuse or because of repetitive stress, when the tendons which are attached to the apophysis, when it results in excessive pulling of the apophysis such that the apophysis undergoes an inflammation, then that is known as Osgood-Schlatter disease. The apophysis of many bones can undergo inflammation. When the apophysis of the tibial bone is inflamed, it is known as Osgood-Schlatter disease. So as I said, since this is it is present only in the children and adolescents because it is still not fused, it is the one which is affecting the adolescents during rapid growth where they are active during the stage. It is usually self-limiting. What is Morton neuroma? Motor neuroma is nothing but that is benign growth of the interdigital or intertarsal nerve. That nerve per se which is present between the digits, there is a growth. The etiology is idiopathic. The pain is aggravated when wearing high-heeled shoes. Due to increased forefoot pressure is present, therefore the pain is extremely aggravated. The treatment is orthostatics or comfortable shoes, and steroid injections also provide relief. So, how will this knowledge be tested in the exam? They will be giving you questions like a middle-aged female wears high heels and has a severe pain under the foot along the second or the third metatarsals. So now you should know that there is growth in the interdigital or intertarsal nerve, and they ask for the answer or how to treat the condition. Orthotics first, and then the steroid injection. The diagnosis is Morton's neuroma. So, what do you understand about tibia vera? Tibia vera is nothing but it is Blount's disease. Here, you should know that vera is anything which is angled inward is known as vera. The opposite is valgus. So, no one as of now. So, here the tibia is angled inward such that the knees appear bow-legged. Since the tibia is angled inward, the knees are pushed outward and it appears as bow legs. Bowing of the tibia until 2 years is normal. It can be observed. But after 2 years, it is known as tibia vera or Blount's disease. This can be either unilateral or bilateral. When there is abnormal growth of the medial aspect of the proximal tibial physis, then it results in tibia vera or Blount's disease. So it rickets, the bowing of tibia caused by rickets is not tibia vera or Blount's disease. The one which is not caused by disease and which occurs after 2 years is known as Blount's disease. What is talipes equinovarus? Talipes is any deformity of the foot or the ankle is talipes. Equino is plantar flexion, that is pointed downward is equino. Varus is inward rotation of the foot. As I told you, any rotation towards the midline, sole facing midline is varus. So when a child presents with talipes equinovarus, the initial treatment should be serial casting. Observation is the wrong answer. So why does this occur? It may be seen in Potter sequence and it is usually idiopathic in etiology. It is totally entirely different from rocker bottom foot, which is seen in Edwards syndrome, which is exactly the opposite. What is arthrogryposis? It is a child who is born with multiple joint contractures. It is not limited to a single joint, but it affects multiple joints, including the elbow, including the knee, including the feet, etc. So, a child with not just a club foot but other joint contractures, then it indicates arthrogryposis. Thank you everyone. With this we have come to the end of our topic. I have an announcement for you. I am beginning my mentoring classes for medical graduates and USMLE aspirants. I am Dr. Veena Velmurugan, anesthesiologist. I love to teach and educate others. If you like my videos and if you want to get mentored by me, you can send a message in the comments. Looking forward to see you succeed. Have a good day.